Okay, thank you very much for your time. Welcome to the pre-exposure prophylaxis evening lecture. I hope that this becomes one of the sessions you will enjoy. We are focusing on HIV prevention. For today, our focus is that I'll just introduce you shortly, just quickly to the school, and then we'll then move swiftly to discuss pre-exposure prophylaxis. Just to say that I'm part of the school, Aqua Training School, which is an accredited school that offers accredited and non-accredited courses. We have a vision which is to help you to achieve your full potential. So hopefully, through these sessions, we are able to help you to do that. We also hope that through these sessions, you'll be able to establish career enhancing relationships with your peers, but also with us. These are some of the training programs that we offer. When you get time, visit our website and register. Pay attention to the HIV management guidelines e-learning, which is free. We are also working on additional 2 programs, including PrEP as training programs, where you can then receive your certificates. Remember to contact us, mainly use the email support@aquatraining.com, whether you want the slides or you want us to help you with any other challenges you might have. That is how you may reach us. So in terms of PrEP, the outline for today's session is that we'll focus on the goals of the ART program, and then we'll have a quick look into new infections in South Africa and discuss some of the risk factors for HIV infection, then go into PrEP exposure prophylaxis. And hopefully at the end, we have enough time to go through at least 1 or 2 cases. So the HIV/AIDS program, or the ART program in South Africa, has a number of goals, right? From improving the quality of life, ensuring that people are on ARVs and their viral loads are suppressed through timely diagnosis and testing. However, for today's session, our interest is to look at, HIV prevention, in the context of reducing new HIV infections. This is just one of the graphs that shows the number of patients who have been put on ARVs. You can see that in the early days, we really struggled as a country to put people on ARVs. There's many reasons. Initially, we didn't have ARV drugs. Later on, we had ARV drugs, but there were some political issues. But as soon as there was political will and commitment, you can see, the rapid rise, in the number of people who are on ARVs. The estimates probably tell us that by the end of this year, we would have crossed 5 million people on ARVs and probably heading towards 6 million people on ARVs. So that is quite positive. The other goal which I referred to is to ensure that all those patients who are on ARVs are actually virologically suppressed. And you can see we are not doing that well in this instance, because we would have expected all patients who are taking ARVs to be done a viral load, but importantly, to also become virally suppressed. So we are not doing well. As you can see, just above, let's say, close to 60% of people who are on ARVs are actually becoming suppressed. On the positive side is that people are living longer, so we don't see a lot of deaths from HIV. Obviously, in today's era, we are talking about COVID-19 as a new virus that's causing a lot of problems. So we will have to look into that. But there is this old comment by Bill Gates, where he was saying that between just a few seconds, I've got something that disturbs me here. Between 2003 and 2005, for each person who was started on ARVs, we had 10 people who became infected, right? And besides everything that was done. And one wonders whether the situation has changed, And let's have a look and see if how things look like. So if you look at the total new infections in South Africa, which is what we are trying to look at, whilst we have increased access to ARVs and increased access to viral load tests and so on, but we have not significantly changed, the trajectory for new infections. So people continue to become infected, on a daily basis, every hour. We are not controlling the epidemic. We sort of have an underlying theory that says let people become infected and we will give them ARVs. Yes, today we use ARVs as treatment, but we prefer that the majority of the population should live, an HIV-free life. And you can see that the estimates are that by the end of this year, we would have crossed maybe we would be very close to having 8 million people living with HIV and AIDS. And one of the questions is why? Why are we failing to reduce the number of new infections? There are, we have a generalized epidemic in South Africa in that the population that's infected is generally a mixed group, not necessarily selecting specific groups. However, as you zoom into subgroups, for example, girls and young women, men sleeping with men, where one has one sexual partner, people who inject drugs, people with recent history of sexually transmitted illnesses, people who recognize their own risk, so there are a group of people that we say they are at a substantial risk. So everyone is at risk in South Africa because we have a generalized epidemic. But we say there are subpopulations that have a substantial risk, which means they are at a higher risk compared to the general population. And for example, sex workers or couples where one partner is positive and the other partner is negative, and we need to look at then how we work with our communities and these subpopulations to ensure that we are able to prevent the transmission of HIV and therefore averting new infections. So there's a lot of studies around this, but I just want to show you that it's very important that when we talk about HIV transmission, you do not separate yourself and say you are safe, right? Because generally we would say people who use needles, people who are men sleeping with men, commercial sex workers, their clients and partners. What is very important is to know that we have a generalized epidemic, and people who are in a monogamous relationship, so it's you and your boyfriend only, or it's me and my wife. If you take the majority of infections in a country like South Africa, yes, we've got subpopulations that are driving the epidemic, but the majority of people who are diagnosed with HIV, when they are asked, they report to be in one lover kind of relationship, and unfortunately you can see that 43% of new cases, the people would report that they are in a very serious sort of relationship long term. About a quarter would report that yes, they are in a relationship but they have other partners, and 22% had reported in this instance that they were partners of someone who is either in a concurrent relationship or who believes that they are in a monogamous relationship. So just remember that yes, we say there are populations that are at a substantial risk of getting HIV. However, we are living in a generalized epidemic, and being in a monogamous relationship has significant risk because half the time you have reduced your relationship to trust and a belief that you are in a one man, one wife relationship. However, your partner might be a partner, of someone else, might be a partner for sex workers, might be a partner of men sleeping with men, and might be using, needles and other things, therefore increasing risk within your relationship there. So quite important. And we have a number of interventions in responding to HIV. the traditional, messaging for behavioral change around the need to abstain, being faithful, the use of condoms, and counseling and testing. So this is a very important message. Whilst it is difficult to measure the impact of such messages, they are important that we continue to communicate. We know that South Africa has a huge male circumcision program, the distribution of lubricants. Now we talk about ARVs as part of prevention. We have seen it in the prevention of mother to child, the use of ARVs to limit transmission from the mother to the child. Post-exposure prophylaxis. As health workers, when we get pricked with needles, we tend to need post-exposure. And then there's also PrEP, microbiocides. The majority have not passed, research level. These are gels that you would apply, around your genital area, the treatment of infections in the genital area, the treatment of STIs, vaccines, and immunizations, not necessarily very effective. Each of these has its own strength, and its own weaknesses. Therefore, no single HIV prevention method is effective on its own. What works best is when we combine, the use of condoms with a circumcised man, and if the partner is positive, making sure that they are on ARVs and treating STI. So you talk about multiple combined interventions for HIV prevention. Now, this is a very important diagram for today because it sort of introduces our topic around pre-exposure prophylaxis to say, whenever you look at your community or your patients and people who present to you as a health worker, you should always classify them as either they are unexposed, that means it's someone who has no ongoing exposure to HIV, right? And for those populations, we always recommend condoms. Pre-exposure prophylaxis is valuable, especially if they are unexposed, but they are at risk. So if you look at an adolescent young girl who is does not have sexual partners, right? Maybe she's still a virgin. She's unexposed because she does not have a sexual partner. But we sort of have this feeling that in the next few months to a year, she might get into a relationship. Therefore, we might need, to offer her some form of pre-exposure, so treatment that she will take before she is exposed. Then there's people who are exposed, right? But they are not yet infected. So if she says, I'm in a relationship and my boyfriend is taking ARVs or something like that, so she is exposed, though at that point in time, she's still negative. If you look at infants born from mothers who are HIV positive, we say they are exposed, but not yet infected, right? And then there's also exposed where now the person has literally been exposed to HIV, right? And we look at post-exposure prophylaxis. That means now, yes, there's exposure, but there was no protection. Therefore, what can we do to avert, or prevent HIV from infecting our client? And once people are infected, then we recommend ARVs. We want to reduce infectivity. We know that if we drive and ensure that HIV or people living with HIV and AIDS are tested and they are started on ARVs and they are virologically suppressed, we would really prevent a lot of infections. So just remember that PrEP, if you look at PrEP, it works on the exposure before one is exposed to infected fluids, let's say through sexual intercourse. As soon as there was an exchange of fluids, being exposed after sexual contact, we then use the language of post-exposure prophylaxis. So this is quite an important diagram. Yes, so what is this PrEP that I'm referring to? So it is the use of ARV drugs, basically, by an HIV negative person, and I think it will also destigmatize ARVs, because so far when we see someone having ARVs, we think they are infected and we start acting, but now we realize that even HIV negative people can actually benefit from ARV drugs. So we are looking at people who are at a substantial risk of being infected with HIV and AIDS before, right? So this is very important if you refer to that diagram, before potential exposure to HIV, right? So we want to prevent HIV acquisition or infection by giving people who are at a substantial risk, we're giving them ARVs to do that, right? And how do we do this? We give them an oral combination of ARV drugs. And this specific tablet would have 2 drugs in it, a combination of tenofovir and emtricitabine, which is TDF and FTC. This is the short codes, as a fixed dose. So it's 1 tab once daily for people who are high risk and who are HIV negative. So in a typical scenario, you get a high risk person, for example, a commercial sex worker, who then comes and says, I have an STI or I'm not feeling well. You screen them, you treat them for the STI, you provide HIV testing, the sex worker tests negative. So you have a high risk person who presents with a negative HIV status, and we want to keep them negative, right? You therefore provide them with information, and if they are willing to start PrEP, you prepare them, and then you'll start them on tenofovir and emtricitabine. Remember, all these interventions cannot be used alone, so we'll still need to encourage A, B, C, the communication there, the use of condoms, treating STIs, but also giving pre-exposure prophylaxis, which is the combination of tenofovir and emtricitabine, right? So what is the difference between PrEP and PEP? So remember, PrEP, you get ARVs in HIV negative people before they are exposed, right? And when we say post-exposure prophylaxis, it is still in HIV negative people. It's very important. We don't give PEP in people who are HIV positive. That's why you must test first. If you test negative after being exposed, the common scenario is the condom-based kind of scenario. You would then give them a combination of drugs, and it must be given within 42 hours. 72 hours, within 72 hours after exposure. So that is quite important, right? And in terms of the concept of treatment as prevention, you have, if you have an HIV positive person, you don't treat them with PrEP, right? All HIV positive people should be offered ARVs. And when we use the word antiretroviral therapy, we mean triple drug therapy, not a combination of 2 drugs, regardless of their CD4 count or clinical stage, right? Which will prevent both horizontal and vertical. So it will, if someone is HIV positive and they get ARVs and they become virologically suppressed, they won't be able to transmit HIV to their partner, which is horizontal, but also we minimize the risk of transmitting HIV to our kids, our infants. So that is quite important. Now, in terms of HIV negative persons, HIV negative people who are at risk, with substantial risk, men sleeping with men, commercial sex workers, adolescent, young girls, people with risky behaviors using intravenous drugs, right, should be offered daily HIV pre-exposure prophylaxis as part of a combined HIV strategy, right? This is from the guidelines in South Africa, right? And it would include, a huge number of people. So if for example, in my favorite program, PMTCT, an HIV negative woman comes in, I test her, she tests negative, and she tells me that, the husband is so busy, he's got a girlfriend there and there, and now she's not sure what we can do for her. Well, there is something we can do for her. The PrEP guidelines allow for women who are at a substantial risk, whether pregnant or not, to receive PrEP so that we keep them negative even during, the pregnancy. So this is quite empowering if you look at how the guideline has approached this. And the PrEP, though it sounds easy, it must be given under these principles. Number one is that we have to ensure that we identify individuals who are at risk. We have to improve access. It's quite important. It is not given on its own. It must be integrated as part of primary health care, sexual reproductive health, but importantly, as part of other HIV prevention interventions. We want to ensure that there's quality of care, but where things go wrong, it's here, the rights-based approach, because as a health professional, you have your own beliefs, right? So if a 12-year-old young girl comes to you and says, hey, I'm sexually active, I need something, then you start telling her about the fact that you are her grandmother, you want to preach to her, you want her, so sometimes we need to be careful, because the groups we are talking about, sex workers, commercial sex workers, men sleeping with men, these are small groups. They tend to hide because they have a fear of being discriminated against, that they won't be given enough information for them to be able to choose. And half the time, their confidentiality, not even about the HIV status, but about the traits they have, that the fact that she's a sex worker, people can very act negatively against you, at that point in time. So it's very important that as you implement this program, you try to pay attention to the populations that need this service, and we ensure that they are respected all the time. Their dignity is always, upheld, confidentiality, privacy. You can give advice. We're not against advice, but make sure that it is at least non-discriminatory and your actions do not limit access to this important intervention. So this is very important. And when you give PrEP, it's not just the drug, right? We give it in the context of HIV testing. You cannot give PrEP unless the person has tested. And as you test people, some will test positive. So access to ARVs is very important. We are talking about high-risk groups who are likely to also have other sexual problems, and STIs being one of them, the distribution of condoms and lubricants, pregnancy screening, increasing access to family planning, which is very key, and then counseling for mental health and TB screening. So it's not just a tablet to be given, it has to be given with other key services for health and wellness, but importantly for HIV prevention, right? So you have to screen. To increase access for PrEP, we have to screen for PrEP, right? We have to screen. And, I wish there was a way I could start with you guys and just screen you now, and say, in the last 6 months, have you had sex without a condom? Have you had sex without a condom with an individual whose status you didn't know? Have you ever had an STI? Have you had sexual relations with more than one partner? Have you had a sexual encounter under the influence of alcohol and drugs? And if you have a yes to any of this, you are a person with a substantial risk for HIV infection, and you would really benefit from PrEP. And then we've got also clients in sero-discordant relationships, so they know already that, well, I'm okay, I have one partner, I don't have any extra partnership relationships, but my partner status is that they are positive. So what the main thing is to assess whether the partner is adherent, is on ARVs, is the partner adherent, and is the partner suppressed? Because if the partner has been on ARVs for less than 6 months, we sort of think, and they are not using condoms at that point in time, we sort of think that the partner is not suppressed. Therefore, the risk of transmitting to the other partner is very high. And these are situations where pre-exposure prophylaxis, plays a significant role, right? So, and also important, even if they say no to all these things, but if a person is requesting PrEP and say, hey, sister, can I have PrEP? Probably it means they need PrEP. So don't say, but you said no to any of these. No, so it will be screening. But if someone says, I'm here because I've heard that there is PrEP, it means they have a concern, and therefore they should be offered an opportunity to be initiated on PrEP, right? So who is eligible? Who qualifies for pre-exposure prophylaxis? So number one is that we only give pre-exposure prophylaxis to people who are HIV negative. So, and not by mouth, but by test. We want test results that show that the person is negative, that they do not have signs suggestive of HIV. So if you suspect that this person might be having early HIV, you want to avoid prescribing PrEP. You want the client to be willing to take, because PrEP only works when people are adherent. They should have no contraindications to tenofovir or emtricitabine. You know, things like kidney problems, 2 classes of protein in urine. You don't want to give tenofovir to such groups of patients. And in terms of adolescents, their weight must be above 35. Why? Because remember, PrEP, you use tenofovir. And one of the requirements for using tenofovir is that the weight must be above 35 kgs. If the weight is below 35, you cannot use TDF. Therefore, they are not eligible for pre-exposure prophylaxis. Now, when do you then say contraindications where you really cannot give PrEP? By all means, well, it's 2 scenarios. Number one, HIV infection. So if the test is positive or the test is negative with a history of recent sexual contact, unprotected sexual contact, but you find that the patient has some fever, sweating, some upper respiratory tract kind of situation where you think they are maybe seroconverting, you know, they're in a process of seroconverting. Yes, the HIV test is negative, but you are very suspicious. You should probably delay PrEP and maybe test that patient 4 weeks, a month later, basically, right? So very, very important. So there's mainly 2 contraindications: HIV infection and a creatinine clearance that is less than 60 mils per minute. So with HIV infection, yes, the HIV test is negative. If it's positive, we don't give. But also if the HIV test is negative, but your patient has signs that they have early HIV, you know, then we want to avoid just by delaying it and testing them again in 4 to 6 weeks from that time. So I hope this slide is clear. And yes, there are tests that need to be done before you start patients on pre-exposure prophylaxis. The first one is an HIV test, because we only give PrEP to patients who test HIV negative. So that's very important. Because we are going to give tenofovir, we want to ensure that the kidney function of the patient is optimal. If you find that the eGFR is less than 60, you should probably avoid pre-exposure prophylaxis. Hepatitis B surface antigen, this is important because remember, tenofovir and emtricitabine also treat hepatitis, but a patient who's got a positive hepatitis B test is not a contraindication. However, we know that they are not supposed to stop PrEP, you know, or interrupt it without attention of the doctor. So if the hepatitis B surface antigen is positive, you start them on PrEP, but then they need to be assessed by a doctor. We screen for STIs, we screen for TB, and then we also do a pregnancy screening. But remember, I've already said that PrEP is not contraindicated in pregnancy. Women who are classified as a substantial risk of being infected with HIV and they are pregnant, they are eligible for pre-exposure prophylaxis, and we should consider it to avoid women who seroconvert, changing from a negative state to a positive state during pregnancy or during breastfeeding. So that is quite important. And these are the drugs that you would then move on to prescribe. You would give tenofovir together with FTC as 1 tablet per OS daily. This drug combination can be taken anytime, whether at night or during the day, with or without food. So the patient's time of choice is preferred. And how do you prescribe it? When you start, you give a 1 month worth of supply, and then they come back after 1 month. And during the 1 month visit, you repeat the HIV test. If it's negative, you then prescribe another 3 months of treatment. However, they collect every month. Obviously, this might change under COVID restrictions because we want to do multi-scripting and to avoid patients coming to clinics unnecessarily. But what is key is that before you start your pre-exposure prophylaxis, you would do an HIV test. At 1 month visit, you'll do an HIV test. Then every 3 months from then onwards, you would then continue to do your HIV test. Right. Sorry about that, just a glitch. Now, important precautions. These precautions are very, should I say, valuable and important. So number one is that it's important that you know that you don't start PrEP today and become protected today, right? So if you start a patient on PrEP, they need to take it for at least a week, 7 days daily, being adherent, for that patient to have adequate drug levels, especially around the genital area. And then during this period, we have to encourage patients to abstain or even to use condoms and other prevention modalities. So remember, you don't start today and become protected today. This is an important message that we must give our clients. And then also when you have to stop, so let's say someone says, I want to stop PrEP, you need to ask them, so when last did you have exposure to HIV? Basically, when last did you have unprotected sexual exposure to HIV? Because yes, you want to stop today, but if you had the exposure last week, you can't stop. You have to continue PrEP for at least 28 days because PrEP will provide that PEP, that post-exposure prophylaxis effect. We count from the last exposure. So that's quite important because if someone was exposed last week and they stop today, there's a likelihood that in the next few weeks, they might seroconvert from an HIV negative state to an HIV positive state. So that is quite crucial for us to communicate these two important precautions. Right. And then remember, counseling is very important. So even in studies, PrEP only works if you take the drugs. So if you stop and take, it doesn't work. So therefore, we have to make sure that we educate our patients around what this PrEP is and how it works, and that it's not a life sentence. You can study it and later on you can decide if you don't want to, but then they must come to a health worker to stop. And then that it only works if you take it. If there's poor adherence, it doesn't work. There's very minimal side effects. There might be minor things, but it's very a good combination of drug. And it doesn't do well with alcohol, but it can be taken with contraception. So it's quite a very fair combination. And that, they're stopping and starting. So when they start, remember, like I said, the full protection will only be achieved 7 days later. And then when to stop, you need to make sure that you don't stop within 28 days from your last exposure. You need to wait for the 28 days to lapse. It is safe in pregnancy and breastfeeding, and women who are pregnant with substantial risk of HIV infection should be offered a pre-exposure prophylaxis. It is safe in conception, and then also when you educate, remember the schedule. You start, you come back in a month. If things are okay, you will come every 3 months from there in terms of your visits. So that is quite important. So in terms of the follow-up visits and what are the things that need to happen during follow-up visits, remember, HIV status must always be negative. We do it before we start PrEP at 1 month and then every 3 months. Ne? And then we want to address side effects every visit, ensure that our patient is adhering every visit. The creatinine clearance is done before you start PrEP and then during the month 7 visit. Then from then onwards, once a year, you must do a creatinine clearance, because as soon as there is deteriorating kidney function, we have to reconsider whether we should continue with PrEP. We must screen for TB and STIs every visit. And remember, the supply follows the schedule. So when you start, you prescribe just for 1 month. At 1 month, you prescribe for 3 months, but they collect the drugs on a monthly basis. Remember here, you are giving ARVs to someone who's not sick. This is for prevention. So adherence is usually an issue, right? Because, of that. And then we have to do behavioral risk reduction counseling and ensure that the A, B, C, D, E are adhered to as much as feasible, right? So this is probably the last slide before maybe we try and discuss a case. So here is just to say that when can you stop PrEP? So sometimes we stop it because the client says, I am tired. I don't want this, I've had it for 2 years and maybe now I'm in a stable relationship and so on, we stop. But generally, if the HIV test at any given time comes back positive, you must stop. If there's renal disease by deteriorating creatinine clearance, you must stop. The client is non-adherent, is playing with the drugs, you probably need to stop. The client says, I don't want this thing anymore. It's fine, you stop. The client does not meet eligibility criteria. That means a low-risk client, really, maybe a non kind of a patient, you probably need to say no. And if there's safety concerns, so if the risks of side effects or adverse events and so on are high versus the benefits of HIV prevention, we should stop. And remember, every time you consider stopping PrEP, you need to assess when last was the patient exposed to HIV. And if it's longer than 28 days, then we are okay. But if it's shorter than that, we want to complete 28 days from the last exposure, just to ensure that we protect our patient. Right. So I think the next one then is for us to do a number of studies. So let me do it this way. Okay, few seconds. Yes, because I want to be able to see you. Right. Great. So let's look at 1 or 2 case studies and then we see how far we go. So here's a case study. So it's Lerato. So this is a case study of an adolescent young person. So we have Lerato, who is a 16-year-old adolescent. She is an orphan and has been brought up by her aunt, who sells alcohol as a means of income. Lerato is sexually active and has a boyfriend. Lerato also does favors for her aunt's clients so they can keep coming back. Her aunt is aware of that and advised Lerato to use injection for prevention of pregnancy. Her aunt does not believe that Lerato can contract HIV from her customers because these are high profile and respectable men. Ne? Lerato is on the other hand thinking of making extra money for herself by doing transactional sex with some of the customers, right? So this is quite common. So the question to you is, can Lerato be considered can we consider Lerato to be a high risk from contracting HIV? Who wants to try? You may unmute. Beauty. You have unmuted. I don't know, by chance or by plan. Do you want to try? Do you think Lerato is low risk or high risk?
It's high risk.
High risk.
High risk. Okay, great, great, great. So we are dealing with a high risk scenario. Is Lerato eligible for pre-exposure prophylaxis?
Yes, he is.
Yes, he is. What would you give her? Who's talking?
Tenamine.
Telamine, yo, sister.
Yeah. Sinafovir, 300 milligram with
Emtricitabine.
200 milligram.
Okay, I'm muting you again. So yes, she is eligible. Why? Because one, she's an adolescent young woman, right? So that is very important for us to note. She's one of those people who are classified as substantial risk for HIV infection. But also when you look at her sexual risk, they are quite high because she's got multi sexual partners. She's an orphan, which puts her at risk, and the guardian seems not to believe that she can become infected. She's only advising her, you know, on family planning. So she is eligible, and you would screen her. You would do some tests. You would do some baseline tests. An HIV test must be done, and it needs to be negative. You'll screen her for STIs, for pregnancy. You'll screen her for TB. You'll do a creatinine to assess whether she's got any kidney dysfunction. And if all those are in place, then you have to counsel her, teaching her about PrEP and how it works, when to stop, when not to stop, and that if she starts PrEP today, she is not going to be protected today, right? She must continue to use condoms and probably avoid, you know, multiple partners for at least 7 days. And then by day 7, usually we've got good drug levels around the genital area, right? So, and then what prevention strategies do you recommend other than PrEP? So you look at other things, behavioral risk counseling, she needs it. She's an orphan, and I think that the aunt is really abusing her as a young woman. So we might need to refer to social workers and other community structures. We might need to assess if she's still in school. You know, we'll distribute condoms, what you call your lubricants, you know. So you'll have to do a proper assessment and counseling of her. So what are the possible disadvantages of pre-exposure prophylaxis for a girl who is 16 years old? Is there someone who wants to give it a try? What do you think are the disadvantages of PrEP for girls or for a young lady who is 16 years old? Anyone who wants to give it a try?
I think it's adherence as well. They won't be adherent to the treatment.
Yes. So number one is that, you know, young women, they don't have a lot of negotiation rights if they are having sexual relationships with older men. These relationships are transactional. She might have to hide the tablets, and she's a young girl. Adherence will be an issue because also the grandmother might not be able to support her because she believes that the young girl won't be infected by these rich guys, right? So very, very important. So your counseling needs to address that. You need to help her how to not to forget her medicines, setting up appointments, getting a friend or someone she trusts who can support her and remind her to take the drugs, right? So I have another case. Again, this one, it's Tom. Tom is a 62-year-old gay man who presents with an upper respiratory tract infection. So he's got some flu-like thing going on, with a history of having unprotected sex 2 months ago. And he did receive post-exposure prophylaxis, and he remained negative during that time, right? He has had a lot of PEP. Every year he gets PEP, you know, and then the primary sexual partner is HIV positive on ART, And now Tom is inquiring. He has heard that there is PrEP, and he wants maybe PrEP. So anyone who wants to try out in terms of what do you think are some of the issues here that which would impact on your approach in terms of PrEP for Tom? So what are some of the things that you think you would really need to check and ensure that they're okay? Or what are your concerns? Puleng, you want to try?
Yes, I'm concerned about that. The partner is HIV positive and it's on ARVs.
Yes, so there you are very correct, because we want to know more information about the partner. For how long has the partner been on ARVs? Is the partner adherent? Do we have the recent viral load? Are we dealing with a very good adherent partner, who is virally suppressed? So that is very important. And remember, if the partner is positive and Tom is negative, we call them discordant couples, right? And in terms of PrEP, we want to protect the negative partner. Yes. Any other concerns anyone has?
Yes, Doctor.
M. Roberts, yes.
I think the other concern would be to check whether to screen for TB.
Yeah.
Because the upper respiratory tract infection could be anything from TB to pneumonia, and maybe we might need to look at that.
Yes, so where pneumonia is usually lower respiratory tract, but obviously if as part of this there are symptoms, whether it's coughing, fever, and so on, we need to screen for TB and ensure that the things are in order. Yes, any other concerns from anyone? Dimakato, you want to try?
I don't know if this was covered because my network is very bad. So I'm worried about the repeat exposures requiring PEP.
Yes.
Like, doesn't it form some sort of resistance when you're constantly taking PEP, like over and over again? I don't know if it's got any effect on that.
No, I appreciate that question. Now, you remember now, PEP and pre-exposure prophylaxis are given to HIV negative people, right?
Yeah.
So you cannot get resistance if you don't have the virus. Remember, it is not a person who gets resistant, who gets mutations. It is the virus, right? So people who are HIV negative who receive either PEP or pre-exposure prophylaxis can never get resistance. Resistance will only happen if that type of a patient now becomes HIV positive and we continue to give PEP or PrEP. That means now we are treating HIV with 2 drugs versus 3 drugs. Therefore, the risk of resistance and treatment failure is very high. So if a person has tested negative, by all means, they don't have the virus. So the virus is not there to become resistant. So that risk is very low, right?
Okay.
But it's a very, and I think the repeat PEPs here, they also tell us about his risk and his behavior, that he regularly becomes exposed to HIV, and maybe we need to do something so that we can protect him, because remember, he has remained HIV negative. So that is very important, right? Any other concerns from anyone?
Yes.
Yes,
I'm
ma'am.
also concerned about the
Okay, wait,
fact.
Puleng, wait. Let's give him Paul a chance.
I'm thinking, because he's been on PEP for quite a while, from 2017, 18, I think also to check his protein creatine clearance, to check if his kidneys are functional, because they say they.
Yes, so that is very important, because remember, look at his age. Do you see his age there? He's 62. He's 62. So we need to at 62, more than half the time, the kidneys don't like drugs. So we need to make sure that his clearance is very good and he doesn't have protein in urine. right? Puleng, are you still there? Puleng, come back. Yes, you wanted to make a comment, and then Vincent,
Oh.
you'll be next. Then we close this case, yes?
Okay, Doc. I'm also concerned that for the mere fact that he has been exposed since he had unprotected sex 2 months ago. So
Yeah.
I think also one of them.
Yes, yes. So he's exposed, and it's 2 months ago, you know. And now, if you look at it, he also has some flu-like symptoms. So remember now, you don't want to give PrEP to people who are HIV negative, but where you suspect that they might be seroconverting. Ne? So you want to really assess this upper respiratory tract infection carefully. And remember, in the guideline, I covered this a bit. I said where you suspect that a person is HIV negative, but maybe they are seroconverting, you need to delay, few seconds. You need to delay your prescription for PrEP and then test them again a month later. And if that test a month later is negative, then you can give them PrEP, right? Remember on the contraindications, I said it is contraindicated to give someone who is HIV positive PrEP. Now, HIV positive has two scenarios. Scenario one, you have done an HIV test and it comes back positive, right? That's an obvious one. Scenario two, you have done an HIV test, it's negative, but when you count from the last exposure, you realize that this person, the way they are sick, maybe they are seroconverting now. You know, remember there's always the window period and the false negatives. So that is very important that you pay attention to that, right? So yes, so I think you have probably raised most of the issues, and I will just to say, does he need PrEP? Yes, he's high risk, and he needs PrEP. We need to educate him, counsel him. We need to ensure that he does not have any contraindications. We need to do baseline assessments, an HIV test again to confirm his status, a creatinine clearance, TB screening, STI screening, you know, and ensure that, you know, everything is in order. And then if he's okay, we'll then give him a tenofovir 300 milligrams daily with emtricitabine 200 milligrams daily. We prescribe for a month. He comes back in a month's time. We do an HIV test. If it's negative, we prescribe for 3 months, and then every 3 months. Remember, the creatinine, we'll do it at baseline before we start PrEP, then at 7 months on PrEP, right? And then every year from then onwards. And he's 62 years, so we have to take care of that. Assess that upper respiratory tract infection. If you think that he's maybe seroconverting from some recent HIV exposure, so a negative HIV status won't mean much. We would have to defer PrEP and then test him a month later. And then if that test is negative, then we can give him PrEP. But remember, sexual risk and sexual health discussions need to happen. He's coming too frequent with PPE. I mean, for PEP, we need to assess sexual partners and behavior and ensure that we are able to help him. So yeah, so I don't want to discuss that because I think we have done so. And just to remind you, last 2 slides to say, remember, PrEP doesn't work on its own, right? We need multi-level behavioral biological. So we need to respond broadly in terms of HIV prevention. This is the last algorithm, which is a summary to say, in summary, how to start your clients on PrEP. Always start with an HIV test. If the test is positive, you do post-test counseling and prepare for ART, right? If the test is negative, you assess now, this person is negative. Are they a high-risk individual, you know? And if they are high risk, therefore you want to, so PrEP, remember, people qualify at 2 levels. Either it's a high-risk person, like a man sleeping with men, an adolescent, a young woman, a commercial sex worker, or the person came in and said, like Tom said, may I have PrEP, please, you know? So, and in addition to this PrEP, we want to make sure that they circumcise, we distribute condoms, healthy lifestyle, if they're positive, ARVs and STI screening and management. If now it's high risk or they request PrEP, you then provide counseling and information. The patient is interested, you must assess eligibility, right? Are they over 15 years of age? Is their weight above 35 kgs? Do they, especially if it's an adolescent, we want to make sure that she's a well-developed person. Physical examination to search for acute HIV infection, right? Where someone is seroconverting, they have some flu symptoms and rash and so on, then you might want to delay. If it's an older person, actually for all patients, you then do a creatinine clearance and it should be above 60. If all these things are okay, then you start your patient on PrEP same day. Remember, you give 1 month course, and then after 1 month, you do an HIV test, STI, TB screening, and counseling. Then they'll come back every 3 months, and then you follow the schedule as prescribed. Right. I hope that was worth your time. And I'm happy that you were able to stay until now. It's exactly 9 o'clock. So I don't know if there's any questions, but before I take questions or comments, let me just search through the chat box and see if I see you guys have been answering. Yes. We have to first check Lerato's weight. Yes, M. Roberts. Let's not forget the weight must be above 35 kgs. She's 16 years old, and she must be well developed. Why MSM high risk? Well, it has to do with the type of sexual intercourse that they do. Remember, anal versus vaginal sex, the risk is quite high with anal sex, and also behavioral risk around multiple partners, and so on. So it's just behavioral like any other population, but obviously anal sex carries a higher risk than the other types of contact. Right. Great stuff. There's 2 more comments. Wow, thanks so much. This was my first time. Welcome, Christina. I hope that you continue to join us. And then Mapi, so you're saying if a client, if a client is TB symptomatic and later TB confirmed, can we delay initiation of PrEP to another 2 weeks? I think it's recommended. We don't want to start ARVs and TB treatment same time. Always treat TB first and then start PrEP later. And remember, TB, HIV co-infection is quite common. So you might want to test your client for HIV as part of your management. And hopefully they are negative. If a patient has a weight below 35 and still requests PrEP, is there anything? No. So PrEP is currently approved for TDF base. So in terms of studies, we don't want to use other drugs that might be toxic. With AZT, your patient will get unnecessary anemia if you use other drugs. So no. So the best drug to give is tenofovir and emtricitabine. So if you cannot use tenofovir, use other prevention methods, distribution of condoms, health education, and support for your clients. Thanks, Dudu. You say the session was informative. Is it possible to get creatinine results same day at the clinic? No, unless if your clinic is very close to a hospital lab. It usually takes 24 hours, probably the next day. But if you do it in the morning and they collect, you might get your results in the afternoon. Will you share as I was late? Yes, we will share the slides through different platforms. Actually, as you ask questions, let me see if I can't download the slides for you. Just a few seconds. Check on the chat box. The slides will appear there, and then you can just click on the slides, but I will still find other ways of sharing, and then you take it. So there will be a document on the chat box. Just click on it. Otherwise, you will get it through emails. And then do we initiate PrEP and review results in a week? Yes. So you may do that. There's no harm in starting PrEP and then reviewing the results later. We don't expect very big problems. So that is quite acceptable. Right. Yeah, so thank you very much for joining in. I don't know if there is anyone who wants to comment, who wants to raise a question. I have 1 or 2 minutes for you. Nasipi, unayo umbuzo? Nasipi, okay. Great. It seems like we are all okay. Dr. Muriba, would you like to make a comment? Okay, Nasipi, I can hear you.
I don't have a question.
Okay, great stuff. Great stuff. Okay, Sister Porter, I see you, Antoinette Porter. Dr. Mriba, do you have any comments?
No, no comment. Thank you. No comment.
Okay. You are welcomed. You are welcomed. I wanted to check. Says Lerato, how are you? Do you have any comments?
Hi, nothing, no comments. Thanks for informative presentation.
Thank you, says Lerato. Colleague says Lerato is our national manager for the HIV program, CCMTT, clinical care, comprehensive clinical care. So issues around advanced clinical care on complicated cases. She's the lead there. Let me see. TC, are you there? Do you have a comment? Then we close. I'm just trying to scroll and give people a chance.
No, thanks, Wellas. Not really, but I'm just thinking that I wish as our guidelines are being improved in terms of PMTCT,
yes,
we can have a standardized assessment at ANC first visit to sift through those women that are high risk of contracting HIV during pregnancy. You know, if it can come as standard as part of your assessment, because well as when you know, we've got so many women that would seroconvert during pregnancy and breastfeeding. And I tell you, if we were giving it as standard PrEP for these women, I'm sure would actually have babies that are getting HIV from others, from their mothers below 2 years. I'm sure we can have them.
No, let me tell you something. I'm sure you have noticed I have mentioned pregnant women more than 3 times.
Yeah.
Or 4 times.
Yeah.
It's because as I was preparing, I noticed that actually this is an intervention which we have not explored. And in the actual PrEP guidelines, the national PrEP guidelines, there's a specific section talking to PrEP and pregnant women and the scenarios under which PrEP must be given as part of HIV prevention in pregnancy. And I think we have to review that and maybe benchmark it and test it and see. And maybe we'll then transition to national guidelines on the PMTCT side of things. But on the PrEP side, it's already included. Maybe we can use that guideline as the basis for that. Yeah. Okay.
I'll look forward to that, seeing that in the PMTCT guideline, you know, it will assist. Thank you.
All right. Thank you, colleagues. Enjoy your evening. We will share the videos and the lectures via different platforms. Thanks for joining us, and I look forward to seeing you next week. Thank you. Bye.
Thank you.
Enjoy.
Bye.
Thank you, so. Bye.
Bye. Remember, if you want anything, whether it's the slides, you can also drop us an email at support@aquatraining.com. Thank you.
Support@aquatraining.com.
Yes.
I want to come as my child kidney.